Hi, this is Dr. Darrin Hansen. Welcome to our lap band seminar. We put this short seminar together to talk about lap bands and specifically our program and how it can best help you with your weight loss journey. I've been doing this for about 13 years and over 1,300 lap band patients. We only do lap bands in our office as a weight loss surgery currently and specialize in that and do more lap bands than anybody in the state or in the region that I'm aware of. So with that, we'll get going here, and I hope you find this helpful, and we're happy to entertain any questions or concerns you may have about the lap band or whether it may be right for you. The population in general has been getting heavier in the United States, to the point that a third of the population almost is in the obese category, which means they are about 30 pounds over their ideal body weight. And with that comes several health issues that will affect society and people's well-being. The population has been increasing. The last numbers that I am aware of are that 25% of Utah is in the obese category. And the numbers are staggering of what's been happening. I won't go into detail with all of those, but know that it's a significant issue. To help determine what is obesity and when do people need help, there is a term called body mass index, which takes in consideration your height as well as your weight and gives you a body mass index number, and that is your weight in kilograms divided by your height in meters. 20 to 25 is normal. Over 25 is considered excess weight by 1 pound, 2 pounds, 3 pounds, whatever it is, up to a BMI of 30, which turns out to be about 30 pounds over your ideal body weight. The charts were compiled by Metropolitan Life Insurance Company 30 years ago, where they decided this is what normal weight is. For example, a 5'4" person should not weigh more than 145 pounds. So if they weigh 150 pounds, that's 5 pounds of excess weight. And then there are increments of 5 categories where a BMI of 40 is termed morbid obesity, and that's about 100 pounds over your ideal body weight. The term morbid is because there's a high likelihood of having some kind of medical condition associated with that weight. Well, you can find those charts, you can find that number on our website, or calculators help you find what that number is. And as I mentioned, there are serious conditions commonly associated with obesity, including diabetes and high blood pressure, which are significant ones that can cause havoc and damage to the rest of your body. Joint pain, stroke, sleep apnea, reduced fertility in women, and many others. The cost of being overweight is also a lot more in the obese category, 37% higher for someone who has a body mass index over 30 as opposed to a normal weight, taking care of those various conditions that I just mentioned. Most of you are very familiar with ways to lose weight. It is a very complex issue and becoming more complex the more data and information that we find. There are diet changes that people can make, physical activity, behavior changes, some drug treatments, and weight loss surgery, which is the most effective weight loss option that there is. It's more costly and has greater side effects, but it's the most significant. There's some recent data that has come out that have shown that the likelihood of a child, for example, being obese in their childhood with a single morbidly obese parent is about 30%, and it's almost 70% of both parents are morbidly obese. There clearly is a genetic component. There are hormonal issues that your brain keeps track of that are controlled by genetic responses in your body that almost limit you or make it hard to lose weight. And it's a battle that people have to fight against in their own genes, their own selves. And there are several different options to try and help with that. There's not just one particular approach that works. It's a multi-modality approach where you need multiple facets of trying to maintain or achieve adequate and healthy weight. I'll talk about excess weight loss as a percentage. So I'll give you an example of a 5'4" woman who weighs 215 pounds and her ideal body weight is about 150 pounds, so that's 65 pounds of excess weight. So if she lost 33 pounds, that would be 50% of her excess weight that she lost, or vice versa. And I'll refer to some other charts in a few minutes that will use that number. And that's how most weight loss surgery and weight loss programs are recorded, is percentage of excess weight loss. Of those weight loss options that are out there in the surgical realm, there are three primary ones that have been more popular, if you will, or known out there. The gastric bypass has been around for a lot longer. The lap band came into being about 25 years ago in Europe, and it was improved in the United States in 2001. I started doing lap bands in 2003. About 6 years after that started, lap bands became more popular than any other weight loss surgery in the United States. Since then, it's kind of fallen off, and now sleeve gastrectomy has become the more popular weight loss surgery for various reasons, and I'll touch on some of those. But of those three operations, I want to just touch bases just a little bit. Most of you probably know what those operations entail, and if not, you can find out that information very easily in research. The lap band will help you lose weight by placing this silicone ring shown here around the top part of the stomach. So there's only a ping pong ball size pouch of stomach above the band, and it's connected to this tubing to a little reservoir shown here that is placed underneath the skin but on top of the muscle, where it can be accessed with a needle through the skin to customize the tightness of this band around the stomach. Its primary purpose is to help people fill fuller faster on less volumes of food and subsequently take in less calories and lose weight. It's the only adjustable weight loss option that's available, and it's the safest weight loss surgery that there is. The gastric bypass divides the stomach, leaves a small pouch so that food is sent down a section of small intestine where it joins other pancreatic and bile juices farther downstream. And people then don't absorb any nutrients through that section of small intestine that's essentially offline. Sleeve gastrectomy is a newer operation that removes 85% of your stomach and leaves about a banana size amount of volume to receive food. That's a primary restrictive operation as well. So of all the slides that I show people, this is probably the most important one for understanding the lap band. The lap band creates a restriction area around the top part of the stomach, leaving only a ping pong size ball pouch, and the opening through the lap band that the food transverses is only about the size of a pencil. As you think about why you stop eating, there are four phases. When you start eating, the first thing that happens is that you become, if you will, not hungry. When you eat further past that, then you feel like you're full, and that means different things to different people. And when you keep eating past that, then you will get sick, and further eating then causes nausea or reverse. How that works is the stomach has some stretch sensors in it, amongst other complicated hormones, that gives feedback to your brain to turn off hunger. So as you start eating food, it takes you through this process until people quit eating, because your body will take you through this process and you'll feel sick and then not want to eat and then vomit before that usually would happen. Well, with the lap band in place, this creates about 5 times the speed through this process, so that people can eat a smaller volume of food and feel like, hey, I'm really not hungry anymore, and feel satisfied. So we have control over that to some degree with the lap band adjustment tubing, where we can help create that sensation to maximize your benefit with the lap band. Because that opening is small and the food is traveling down through the equivalent of a funnel, If you eat too fast or too much or don't chew your food well enough, you can back up into what I call Big E, or the esophagus, which is the no loitering organ of the body. If it's not going down, it will send it back up. And so you will trigger vomiting with food that can potentially get stuck if it's not of a consistency that will pass through a pencil-sized opening. Well, consequently, there are some foods that are more problematic for that process. Heavy red meats that aren't cut up very small can be a problem. White bread in any significant amount. Fibrous foods such as asparagus or celery or even fruit peels. Each of those things can get stuck in the neck of the band and then trigger vomiting or have some sense of discomfort. So you have to be careful about eating those things. The biggest issue is that you go slow and careful and pay attention for each bite that you swallow. On the other side of the equation is there are some foods that can sabotage you or are very easily to get down, and that is primarily liquid calories. So we ask our patients to stay away from liquid calories as much as possible, and also to help keep the food more solid, to not drink with your meals and wait for about 2 hours. So you can drink like water up until you're starting to eat. Drink 2 cups of water, then put it away. Don't have it out there because a lot of people will have the urge to just drink with their meal. Then you're trying to eat the smallest amount of food that it takes to feel like that you're satisfied. And that's the stop point that you're looking at. Not that you're full or sick or, that you're having pain. And then you're done. And wait for about 2 hours before drinking again, and that'll help you feel satisfied, not hungry until you get to the next meal. The other thing to do is to avoid any high-calorie liquid foods such as cheese soup, for example, whipped cream. Avoid liquid calories. Chocolate is a liquid calorie. Ice cream, Jamba Juice, milkshakes. We have people stay away from soda pop, even calorie-free. What we found is those people who drink even diet drinks don't lose as much weight as those who stay away from it. I believe that is primarily because when you're eating or drinking, as it is, soda pop, you're putting something sweet into your mouth that then turns your pancreas on, which can produce insulin that drops the blood sugar level. And when your blood sugar level drops, it turns on hungry to help preserve you because your blood sugar is low. If your blood sugar gets too low, you will die. And so your brain will help keep you alive by letting you know that, hey, blood sugar is getting low, you need to eat, and that is a hunger behavior mechanism preservation process. So you will feel more hungry, especially if you have nothing to absorb in your intestinal tract. So then some people will be, okay, I'll have 2 Big Macs with my 44-ounce Diet Coke. Stay away from soda pop. When the lap band's adequately adjusted, it looks like this in the middle, where it says right amount. We can control how tight that is, and because there's adjustability, there is a possibility of not having enough or having too much. When someone comes in for adjustment, the primary question is, are you hungry in between meals? And then, are you eating larger portions or smaller portions before you feel like you're satisfied? And then the third question is, are you losing weight? Because if you're really not hungry in between meals and your size portions that you're eating are small, you should be losing weight. And we wouldn't do an adjustment. The amount of constriction around the stomach varies, and we can adjust that, and including over-adjust it where it could become too tight. If that happens, then people will get heartburn. It'll be difficult to get food down through the lap band. People will actually not lose as much weight because then they turn to liquid calories, and you can get down a lot more liquid calories than you would if you were eating solid food. So you don't want to be there. So how well does this work? I have a table of patient averages for their weight loss. These are my patients. These are not out in the medical literature or down the street. These are my own patients. There's 281 patients that are shown here with an average weight of 266 pounds with a BMI of 42. And if you look at this, there are benchmarks for weight loss. And at 3 months, with averaging these patients out, people will lose about 23% of their excess weight. So if you're 100 pounds overweight, that would be 23 pounds, 3 months. At 6 months, 31%. Out a year is 39 or close to 40%. Out 18 months, it's still close to that. And then as you go out to about 5 years, it ends up being about 50+% of their excess weight. That weight loss tapers off at about 2 to 2.5 years where people will end up. So most people, what weight they will lose, will have it off by then. It's close to about a 2-year period of time. Here's a graph showing not my results, but that are published out there about the long-term effects for a lap band. Out of Australia, Paul O'Brien published 15-year data. And the gold line you can see is what weight people will lose and keep off. So it's about 45% of their excess weight out 15 years. They hold it at close to 50 for about 10 years. And there's a little bit of a drop there. There was some data early on the sleeve studies that showed a continual weight regain after about 2 years. And if you plot that out, if that continues on that, then there may be, for some people, an average gaining of their weight. I suspect that there's some significant chance that they'll continue to gain weight because you have a smaller pouch with a gastric bypass, and some of those patients can certainly gain their weight back without other modifications. What about complications? So in 2010, this data was reported and shows of Center of Excellence facilities what the complication rate was, not what type, but whether there was one or not. And for a lap band, out of nearly 23,000 patients, there was a 6.3% chance of having a complication. For a gastric bypass of getting close to 31,000 patients, there was a 1 in 4 chance of having a complication. And for a sleeve gastrectomy, which was early in the data, it was about 18% of only 1,300 patients. And the next line shows if you had one complication, what's the likelihood of having another one. So it's 4.6% for a lap band and 15% for gastric bypass and almost 11% for a sleeve gastrectomy. So significantly different. So what you want to know, though, is what the complication rate is where you're having a procedure or by what surgeon. So I will show you that information. But to first understand one of the complications, I have this little demonstration that shows you what happens when someone eats too much, too fast, or doesn't chew their food well enough, and it triggers vomiting. Your stomach will slap up against your lap band like this and push through the lap band so that it ends up looking like this, where there's too much stomach above the band. That ends up being like pulling a towel through a napkin ring. The more you pull, the tighter it gets, and then people can get heartburn, pain, vomiting, and then it would need to be revised. This is what we call a slip, and the likelihood of that happening is not very high, but it's still a real number. And so I encourage people to be very careful about any significant vomiting, to chew your food well, go slow, and eat carefully so you don't have a bunch of vomiting. Well, I looked at my slip rate over this 13-year period of time, and it's about 4.8% of 1,144 patients. And about 5 years ago, I modified the operation so that I sewed the front part of the stomach together, which created a thicker rib of stomach so that there was less chance of pushing that up through the lap band. And then looked at the data over this period of time, and for that 4-year period of time, the slip rate dropped from 5.7% from 2003 to 2011 to 2% after that period of time for a 4-year period. Significantly better, which I believe is from that modification of the operation. But it's still significant risk, and so I warn people to be very careful about that. Port problems, where the port may turn, tip, wear through, is about 4.5%. I've kept track of that for a while, but I haven't had very many port problems since they've modified the port to have a sleeve covering over where the tubing goes through the abdominal wall so it doesn't wear through very much, and I have not seen one of these wear through things since they've made that modification. The port is a little bit wider. It's not as high as it used to be, so there's less chance of it flipping over, kind of like a Humvee. And those mostly can be fixed in the office. Erosions are probably the more significant complication. There's about a 1% chance of that. That is where the lap band will pull in through the wall of the stomach, and if you looked inside the stomach, you would see the lap band, kind of like a wire cutting through ice. Now, people don't really feel that happening. They feel the results of it, where you lose the restriction and feel like that you can start eating more. And the best test for that is to put a scope down there and look and see if you can see the lap band. If you have an erosion, then that needs to be removed, or it can get infected, letting bacteria out of your stomach. And we can do that still laparoscopically, but if that happens, then we take the lap band off, game over. You lose your band. And there's a significant chance of re-erosion if you just put another one back on, so I generally don't do that. The likelihood of needing to have it removed is under 5%. All the erosions would need to be removed. One of the treatments for a slippage can be to just remove it, but then you don't have your lap band, and it's like stopping your diet. Most people will gain weight back. And the other category I list here is intolerance, meaning that they just can't feel like they can get a hold of this, and I'm eating too fast and I keep vomiting, or it hurts, or pain, or whatever the problem is. We can take the lap band off in about a 30-minute operation. Still have it done, go home same day, usually about 3 small incisions. So not a high likelihood of having it removed, despite what you may read or hear. Now, I'm sure that there are patients who have gone other places and had it removed that I'm not aware of, and so this number is actually higher than what I list here for that reason. The likelihood of other complications, such as a blood clot to the lungs, is very low, and I've never had anybody die directly from the operation. I did have one person have a stroke the day of surgery from clot in their heart from an undiagnosed condition that we didn't know about, and ultimately passed away, but not directly related to the operation. So, very safe operation. Here is some other data, not my patients alone, that shows the weight loss with the lap band on a national study of 500 patients. I do have some patients that were enrolled in this study that shows a 53% excess weight loss at 2 years. Weight loss can improve fertility in women, physical ability, quality of life, overall wellness, improve diabetes, heartburn, reflux symptoms. When I get done with this operation, people's heartburn is generally gone. Here's a study showing a 90% improvement or total resolution of their heartburn symptoms. This is out of Australia. It creates an extra barrier to keep food from coming back up the esophagus. I am very aggressive at looking for hiatal hernias, where the amount of space around your esophagus as it comes through your diaphragm, that is a small, thin muscle that's almost nipple level on the chest of where it starts. If that opening is too wide or loose, I'll tighten that up with some stitches, and about 3/4 of people who I do a lap band on, I tighten that up or fix a hiatal hernia. That will lessen the chance of having heartburn later and decreasing the chance of actually even having a slip, according to some other studies. So I'm very aggressive at fixing that. Here's another set of studies showing the improvement or resolution of diabetes in up to 80%. The green and yellow are bars. Each of those are studies that show those numbers. The blue is a gastric bypass. The green and yellow are lap band, and you can see different studies showing, again, improvement or complete resolution of diabetes with a lap band. Here's a study that shows that 94% of people are happy with their lap band out at about 48 weeks. For those who are candidates of the lap band, the Food and Drug Administration, the FDA, oversees criteria, which are that you need to be at least 18, you need to have at least 30 pounds of excess weight with other weight-related conditions, or have a body mass index of about 40 or higher, that's about 100 pounds. You've tried to lose weight by some other means and not been able to do it. don't have some condition that would keep you from losing weight, such as like hypothyroidism, or there are some others, understand what it takes to make this work for you and be able to come in for adjustments to maximize the success. And this is why we have you either attend the seminars or watch these educational videos to get that information. I do have slides of before and after pictures. Now you can find good before and after pictures for any diet program, and these are not quite as important as some of the other primary principles, but there are a significant number of people who have not been able to lose weight by any other means and have diabetes or other medical conditions that have not been well controlled, and with the weight loss be able to improve or resolve those symptoms and change their lives to the point where they have not been for a significant period of time or most of their years. I have all kinds of stories that I could tell you about people getting off their blood pressure pills or being more active and then starting to run races and improve their lives and increase their happiness because of their abilities. It really does improve your health as well as your outlook. There's a significant amount of savings that people will be spending for weight in general, even doctor's visits, labs, specialty visits, other dieting programs, eating out-of-pocket health expenses. All those add up over years, and with improvement of weight by investing in a lap band, those can be significantly diminished. Most people want to know about whether their insurance covers the lap band. When I first started this 13 years ago, there were no insurances that covered the lap band, and since then a lot of the major national carriers have covered it. It's really one question for your insurance company, and that is, do you cover weight loss surgery, yes or no? If they do not cover any weight loss surgery, they won't cover it. Just like if you break your windshield on your car and you don't have windshield replacement policy, they're not going to cover it, no matter how much you need it or want it. But if they do cover it, then they have criteria that you have to meet to be able to have them approve financing for it. And we can help you with that by talking to our office. We know most of the insurances that cover it and what their criteria are, or we can find that out for you. They can make it very difficult, and so let us help you with that process, and then we can let you know what your options are. If you do not have insurance that covers it, but are able to pay this out of pocket, so to speak, or self-pay or whatever verbiage, then here are the prices. The cost when we first started doing this was $17,500 in 2003 at Altaview Hospital, where I helped set up the first lap band program in the Salt Lake Valley. In process of refinement and efficiencies, we've been able to get that cost significantly down. It's still close to $15,000 if you do it at the hospital, including the facility, surgeon, assistant, anesthesia, all of that packaged into one number. And I helped set up I set up the first outpatient general surgery lap band surgical center program in the state. We did that at a facility called Southtown Surgery Center, which is now Lone Peak Surgery Center on the Lone Peak Hospital campus, and I've been able to get that price significantly down to $11,500. If you're paying with cash and not using a credit card, you can save on the cost that we have to send a Visa, and so it is currently now $10,975, and that includes everything to take care of you for a year period of time. That includes the general operating day, the follow-up visits, the support group, needles and syringes, everything we can do to provide a service for you for a year period of time. That does not include, in the unlikely event that we need to have a bigger incision or transfer you to the hospital, need services, personnel, or testing. Those would be in addition to that price, which would be very rare. And it is a tremendous value for you. And that gets you into our program for an indefinite period of time for discounts for subsequent follow-up visits, potential operations, or care in the future. Most people want to know, well, so what happens after the first year? We have package plans where you can get about $350 for an additional year of unlimited amounts of visits for adjustments, or $75 for a single adjustment if you want to just do it that way. So if you feel like this is something that you're interested in, here are the steps to take. We gather information that you normally would provide any healthcare office, surgeries, allergies, medical conditions. I review that information to be sure you're a candidate and there's not any concern. If you're paying out of pocket, that has to be paid up front, or if it's an insurance issue, then we need to get pre-authorization for that, and then it can be scheduled. Getting into the operating room is not the bottleneck of this process. We want to be sure that you're ready. We have you come to a pre-op education meeting with us in the office. That can be done at the same time as I would see you, and go over some more details about what am I going to eat and when, types of food. And then I see you in the office within a week period of time to go over any medications, answer any questions, review a few highlights, and then your surgery could be scheduled within the next week. If somebody's ready to go through this process, we can usually get them a surgery date within the coming week. We do have you do a pre-op diet 2 weeks before. Most people don't know that when you first start losing weight, that it comes off your liver first. And one of the incisions of the 5 incisions that I use are to hold the liver up. And if that liver is significantly overweight, it can make the operation a lot more difficult and with a higher chance of having a complication. So we have people do a 2-week diet prior to their operation, which will help shrink your liver up to 25% in some studies. And then we have your surgery date, and off you go. You're primarily on a liquid diet for the first couple weeks, and then you move over into mushy food for another couple weeks, and so you're eating then just regular food at about 4 weeks, and the first adjustment is at 5 weeks, where we have you come in and ask those questions that I mentioned before. Are you hungry between meals? What portion size are you comfortable with? And most people will need an adjustment where we place a needle through the skin and access the system and start putting fluid in. Then see you at least on a monthly basis while you're actively losing weight, sometimes more frequently than that, to fine-tune it to sneak up onto the ideal amount of fluid that you should have in your lap band. And each person is different, and it's a changing number. So we may get somebody up to 5 cc's, and as they lose weight, it can get a little looser, and we may need to put a little more in, or take a little bit out. There's other conditions that would require that, and that's primarily due just on questioning. If there's any concern about the lap band, then we'll do swallow studies where you can drink some contrasting material that shows up on an x-ray, and we can see the size of the pouch and determine whether there's a slip, or other studies whether there's an erosion or some problem. Overall, people do well with this, and it can be a tremendous tool in helping you to be healthier and to potentially be happier in your life with this. Most people can get back to full-time desk job type things within a week. You can do whatever you can tolerate activity-wise afterward. I've never had anybody do something to themselves that caused a complication or problem from any activity that they were engaged in. The 5 small incisions are closed with absorbable stitches and covering so that you can get them wet anytime in the shower. We have you come back and see us in a couple weeks to check your incisions and make sure everything's going okay. And then off you go to the schedule that I already mentioned. I appreciate you joining us during this brief seminar that will go over most of the information that you'll need to make an informed decision about the lap band. We are certainly open for live visits, phone calls, emails, return seminar attendance times to help people feel like they're comfortable and understand what it takes to be successful with the lap band. We wish you well on your endeavors, and if we can help you in this process, we'd be happy to do that and look forward to working with you. Take care.